Hello, my name is Yanisol Torres, and I'll be presenting on healthcare and beyond. Healthcare in the U.S. The campaign for some form of universal government funded healthcare has stretched for nearly a century in the U.S. On several occasions. Advocates believed that they were on the verge of success, yet each time they faced defeat. The evolution of these efforts and the reasons for their failure make it an intriguing lesson in the American history and character. Other developed countries have had some form of social insurance that later evolved into national insurance for nearly as long as the U.S. has been trying to get it. Some European countries started with compulsory sickness insurance on the first systems for workers beginning in Germany in 1883. Other countries, including Austria, Hungary, Norway, Britain, Russia, and the Netherlands, followed all the way through 1912. Other European countries, including Sweden in 1891, Denmark in 1892, France in 1910, and Switzerland in 1912, subsidized the mutual benefits societies that workers formed among themselves. So for a very long time, other countries have had some form of universal health care, or at least the beginning of it. The primary reason for the emergence of these programs in Europe was income stabilization and protection against the wage loss of sickness rather than payment for medical expense, which came later. Programs were not universal to start with, were originally conceived as a means of maintaining income and buying political allegiance of the worker. What was the U.S. doing during this period of the late 1800s and 1912? The government took no action to subsidize voluntary funds or make sick insurance compulsory. Essentially, the federal government left matters to the states, and the states left them to private and voluntary programs. The U.S. did have some voluntary funds that provided for the members in the case of sickness or death, but there were no legislative or public programs during the 19th or early 20th century. During the Progressive Era, President Theodore Roosevelt was in power, and although he supported health insurance because he believed that no country could be strong whose people were sick and poor, most of the initiative for reform took place outside the government. Roosevelt's successors were mostly conservative leaders who postponed for about 20 years the kind of presidential leadership that might have involved the national government more extensively in the management of social welfare. Rhode Island Congressman Amy Forand introduced a new proposal in 1958 to cover hospital costs for the aged on Social Security. The AMA undertook a massive campaign to portray a government insurance plan as a threat to the patient-doctor relationship, but by concentrating on the age, the terms of the debate began to change. For the first time, there was a major grassroots support from seniors as the pressures assumed that the proportions of a crusade. In the entire history of the National Health Insurance Campaign, this was the first time that a groundswell of grassroots support forced an issue onto the national agenda. Finally, in 1965, Johnson signed into law as part of a Great Society legislation capping 20 years of congressional debate. Health plans are investing in and paying for an increasing amount of care covered by risk-based contracts. And these contracts aren't just the obvious accountable care organizations, also known as ACO, and patient-centered medical homes, PCMH, large health systems and integrated delivery networks are also engaging in various forms of risk-based contracting. What's prompting healthcare plans to make such dramatic change? First, insurers can't do much with fee-of-service programs to keep costs down. As its core, fee-for-service incentives provides to see more patients. Risk-based contracting flip the incentives, where providers profit when patients are healthier and don't require hospitalizations. The U.S. healthcare industry stands at a critical juncture. While facing a significant increase in the number of customers who will need to be served, the industry is being tasked by the nation to increase quality of results to ensure consistent quality between rural and urban providers, to be accountable for outcomes, to provide accurate measures of success, and accomplish all these with lower costs. Information technology forms an important part of the solution. Accurate and up-to-date information is essential to continuous quality improvements in any organization, and particularly so in an area complex as healthcare. However, information systems must enhance rather than hamper the role of the healthcare providers. The switch to value-based reimbursement has turned the traditional model of healthcare reimbursement on its head, causing providers to change the way they bill for care. Instead of providers being paid by the number of visits and tests they are ordered fee-for-service, their payments are now based on the value of their care they deliver, value-based care. A lot of this change is long overdue and quite exciting because it's driving improvements to the delivery of care by mandating better care at a lower cost. But for those providers and healthcare systems, they can achieve the required scores. The financial penalties and lower reimbursements will create significant financial burden. The Patient Protection and Affordable Care Act, also known as the Affordable Care Act, or ACA, is the landmark health reform legislation passed by the 111th Congress, signed into law by President Barack Obama in March 2010. The legislation includes a long list of health-related provisions that began taking effect in 2010 and will continue to roll out over the next 4 years. Key provisions are intended to extend coverage to millions of uninsured Americans, to implement measures that will lower health care costs and improve systems efficiency, and eliminate industry practices that include rescission and denial of coverage due to pre-existing conditions. Medical liability reform. The current medical liability system is at its odds, and efforts to transform the healthcare system to that recognize and rewards quality, with an estimated 20 to 30% of healthcare spending going to care that was wasteful, inefficient, and redundant. Our medical liability system generates billions of dollars in unwarranted costs each and every year. EHR, Electronic Health Record, is a longitude electronic record of patient health information generated by one or more encounters in any care delivery setting. Included in the information are patient demographics, progress notes, problems, medications, vital signs, past medical history, immunizations, laboratory data, and radiology reports. Latest healthcare technology. A new generation of battery-powered tools that use ultrasonic radiofrequency laser of light energy is enabling a whole new range of minimally invasive surgical procedures. This has become a reality due to advances in low-power electronics miniaturization, and battery energy density. These smaller self-powered instruments not only are less invasive but also have potential to improve infection control and patients' outcomes. Medicare, Medicaid, and private insurance. Medicare's deductible for 2015 is Part A is $1,260. Part B, outpatient, is deductible is $147 yearly, 20% coinsurance. Part B premiums is on income based. Part 8 must earn work credits or disability 2-year waiting period. Medicaid government insurance must meet poverty income-based criteria, children and pregnant. TANF money granted money monthly to families. Private insurance, you can reach out to a medical insurance broker. They can set up the prospects to what meets your needs. Canada versus U.S. healthcare. Canada provides universal access to healthcare for its citizens, while nearly 1 in 5 non-elderly Americans are uninsured. Canada spends for less of its 10.4% versus 16% in the U.S., yet performs better than the U.S. on two commonly cited health outcomes measures, the infant mortality rate and life expectancy. Medicaid reform. The ultimate goal for Medicaid reform must be mainstream families out of falling program and into more popular private health care options. By allowing Medicaid dollars to follow the individual, beneficiaries would have the same choice to cover and be able to participate in private market just like the rest of the citizens. The healthcare consumer, the information everywhere phenomenon leading to the engaged consumer. Transparency is the word of the decade, from the prices of drugs in hospitals to the clinical facts about conditions to the scope of doctors and treatments shared on social media. Any information we want will be readily available. Thank you for your time, and hopefully you enjoyed my presentation.